welcome everybody to the session. And so this is a session, organized session on the economics of tuberculosis in low and middle income country settings. We have 4 scientific presentations, and then we will have a discussant, and then we will open the floor for questions. My name is Nicola Menzies at the Harvard T.H. Chan School of Public Health. First up in terms of our presentation, we'll have Matt Quaife, if you want to wave, Matt, from the London School of Hygiene and Tropical Medicine. Then we'll have Jinyi Zhu at the Harvard T.H. Chan School of Public Health, followed by Nicola Foster of the London School of Hygiene and Tropical Medicine, followed by Allison Portnoy of the Harvard T.H. Chan School of Public Health, and finally rounded out with our discussant, Sedona Sweeney of the London School of Hygiene and Tropical Medicine. So if you have already been to some sessions today, you'll understand how this will work. We're going to have relatively short presentations, only 8 minutes each. No questions between any of these different presentations, only opening up for presentation after our discussant. So we should have approximately 15 minutes for questions at the end. If you do have questions, you can put those in the chat or raise them at the end. And please make sure with your questions that you make them constructive and concrete. With that, I would like to hand over to our first presenter, Matt Quaife.
Thanks very much, Nick. Good afternoon, good morning, good evening, wherever you are. My name's Matt. I'm a health economist at the London School of Hygiene and Tropical Medicine. I'm going to be presenting some work we've done recently on the cost effectiveness of tuberculosis vaccine in South Africa and India. This presentation takes a health system perspective on the cost effectiveness analysis, and Alison will come back in our 4th presentation and talk about how our work has evolved and is taking a much broader perspective than taken here. Okay, so I'm not sure how much background I need to give, considering you've joined a session on the economics of tuberculosis and analyses, but over the last decade, TB's killed more people than any other single infectious agent. The last year or so, that's changed, understandably. And for the last 100 years, we've had one vaccine, the BCG vaccine, which has been really good at preventing extrapulmonary TB among children. But the majority of morbidity and mortality from TB disease today comes from pulmonary TB among adults. The MTB targets are the goals, the kind of advocacy goals that have been set to really reduce the burden of TB by 2030, but progress towards those has been really slow, and it's unlikely to be met unless we develop and implement an effective vaccine. So in 2018, there was some good news on this front. This vaccine that we will call M72 was shown to have 50% efficacy in preventing pulmonary TB among people, adults aged 18 to 50. So previous work has looked at the epidemiological impact of vaccine candidates, but there's been very little work looking at how cost effective they may be. There's been some work looking at routine vaccination amongst younger children and in mass campaigns, but less work looking at routine vaccination among adolescents. And adolescents could be really key. Routine vaccination among adolescents could be really key to getting these vaccines out efficiently and in an impactful way. And previous work has looked at the impact of vaccinations with post-infection efficacy only. So why is that important? Well, TB, the majority of people who are infected with TB have subclinical TB. They're not walking around being sick. And there are 2 ways that a vaccine could work. A vaccine could stop an uninfected person becoming infected. It could also stop an infected person becoming ill with TB. So this work looks at both types of vaccines, and I will come back to that as we go through. In true IHEA form, it seems this year, I'm going to whiz through my methods because these slides are available in the things we uploaded before. But in brief, we used a age-structured compartmental dynamic tuberculosis model, calibrated to the TB and HIV epidemic in South Africa and the TB epidemic in India. And we assume that a vaccine is introduced in 2025. We take a health system perspective, and we assume that the cost effectiveness thresholds that we will use are those of the York group of Ochulek et al. We have 3 scenarios of routine vaccination, which I'm going to talk through. So the three scenarios correspond to three different age groups of 10-year-olds and 15-year-olds. So in these two younger groups, among 10-year-olds and 15-year-olds, we assume we can reach 80% of people. In the slightly older group, among 18-year-olds, we assume that we reach a slightly lower coverage of 50%. So that's to reflect potential difficulties in reaching 18-year-olds who may be out of work or education. That's a nice picture of the model. There are some nice graphs, and again in this in our kind of methods bits, and nice information about our costs, which I'm not going to dwell on. One thing I will dwell on, however, is it's really difficult when you're doing these models to know what a vaccine is going to cost to buy and to get into people's arms. We assume in this study that a vaccine cost is going to cost, our central estimate is $5 per person for the price of a vaccine and the cost of getting into people's into people's arms. The costs of getting a jab into someone's arms, Allison and others have done really good work on this, is generally about $2 or $3 in many settings. The cost of the AstraZeneca, the price of the AstraZeneca vaccine is about $2. So this analysis is the COVID equivalent of this is the AstraZeneca vaccine delivered in ways that HPV and other vaccines are being delivered. If it cost, in reality, if the price is something like the Moderna or the Pfizer vaccine, which is 7 or 8 times as much as the AstraZeneca one, this is a very different picture that we're going to paint. Again, I'm just going to run through and highlight the important methodological aspects that we assume that basically nothing else changes apart from the vaccine being introduced. There's no change in TB care. There's no change in drug-resistant dynamics. We have a probabilistic sensitivity analysis forming part of our main results with 1,000 runs. We discount costs and DALYs by 3%, and we use the Oculek thresholds presented there. So to summarize how we're going to present these results, I'm going to show a set of diagrams in a second that have 2 rows. Now the top row refers to 3 scenarios. The top row is our vaccine with efficacy pre and post-infection. So in the top row, this vaccine is stopping you from getting infected with TB disease. It's also stopping you from becoming sick if you are infected with TB bacteria. We have our vaccination ages are the columns. So we start with 10-year-olds and 15-year-olds, both again at 80% coverage, and 18-year-olds at 50%. So the top row is stopping you from getting infected with TB and from getting TB disease. The bottom row is this post-infection only vaccine that's stopping you from becoming sick once you are infected. So here are our results. Here's the top row, our pre and post-infection efficacy. On the left-hand side of each of these cells, you can see our cost effectiveness plane. And on the right-hand side of each element, you can see the cost effectiveness acceptability curve. This first slide is for South Africa. The top row, we see a pre and post-infection vaccine being highly cost effective at the thresholds that we consider. The bottom row, we see that a post-infection only vaccine is pretty much always cost effective. The takeaway from this slide is that giving either vaccine to any age group in South Africa is likely to be cost effective. As we move to India, it's a slightly more nuanced picture. Again, in the top row, though, we see that a pre and post-infection efficacy vaccine, something that will stop you getting infected and also stop you getting sick, is likely to be highly cost effective at the Oculek thresholds. However, the opposite is the case in a post-infection only vaccine. So something that stops you just from getting sick is unlikely to be cost effective, a less than 6% chance of cost effectiveness in India. Thank you, Nick. I have a minute left. I'm just going to highlight something in our results. Again, the information is available. The societal perspective, everything gets more cost effective in our societal perspective. The cost ineffective India scenarios do not become cost effective. We have some limitations about the characteristics and implementation, that everything stays the same. We have quite a long duration of protection of 15 years. We assume that there's some we know there's some limitations to our data. For example, we assume that adolescents have similar patient costs to those among adults. I am going to just finish on the implications. This strengthens the case that we need to develop these vaccines. We need to include the right populations in where they are trialed, and we need big enough trial populations that we can consider both of the pre and post-infection dynamics. One interesting result we found is that the ICES was quite similar for vaccinating 50% of 18-year-olds and 80% of 15-year-olds. I'll finish by acknowledging the Bill and Melinda Gates Foundation who funded the work, and look forward to taking questions at the end of the session. Thanks very much. Over to you, Nick.
Great, thank you, Matt. And I think as we mentioned before, if you have questions, please write them down because we do want to return to them at the end of the session. Don't let them be lost. And so now I'd like to hand across to Jinyi for our second presentation. Jinyi, the floor is yours.
Thanks, Nick. Hi, everyone. I'm Jinyi Zhu. I'm a PhD candidate in health policy at Harvard University. I am presenting on behalf of my co-authors on a project about health and economic implications of an isoniazid preventive treatment expansion program among people living with HIV in Tanzania. So TB is the leading cause of mortality among people living with HIV, causing more than 1/3 of all AIDS-related death in 2015, according to the UNAIDS. Isoniazid preventive treatment, or IPT, is effective in preventing progression from latent TB infection to TB disease. IPT is found to be cost-effective in many studies and is recommended by the WHO among all people living with HIV without active TB. However, the coverage of IPT remains low in many high-burden countries, including Tanzania. So expanding effective coverage of IPT is therefore critical in high-burden settings such as Tanzania, and understanding the associated health and economic implications can inform decision-making for efforts to expand coverage. The Management and Development for Health, or MDH program in Tanzania provides an opportunity to investigate the implications of such IPT expansion programs. MDH is an NGO that supports HIV clinics in Dar es Salaam, Tanzania. From 2014 to 2020, MDH expanded its IPT coverage by increasing both IPT initiation and completion rates. In working with local stakeholders in Tanzania, our objective was to use the IPT expansion in MDH as a case example to first evaluate the economic and the health consequences of the observed expansion in MDH. And then we were also interested in further exploring an ideal scenario where IPT had been perfectly implemented. To perform such analyses, we developed an individual-based TB-HIV co-infection model. The figure shows the schematic of our model structure consisting of 3 dimensions of health states: core TB states, HIV states, and TB drug resistance. Our model cohort included all people living with HIV who initiated ART in MDH from 2014 to 2020. And to parameterize our model, we directly estimated some parameters from the MDH data and calibrated other parameters that cannot be directly observed to observe cases and death outcomes using a Bayesian approach. More details on the simulation model and calibration results could be found in our pre-recorded presentation online. And using this well-calibrated model, we simulated and compared 3 IPT implementation scenarios: no IPT, observed IPT, and full IPT. In the no IPT scenario, we assumed that no one ever received IPT in this cohort. In the observed IPT scenario, we reproduced the empirical trend in IPT initiation and completion in MDH, so that the scenario mimics the expansion program in reality. In this last hypothetical full IPT scenario, we assumed the most ideal case in which every individual who's eligible received IPT 1 month after ART initiation, and also a perfect completion rate. Here we show the results on the epidemiological effects using no IPT as the comparison group. Panels A and B show the cumulative TB cases and TB death averted with respect to time since ART initiation. Both observed and full IPT resulted in significant and substantial long-term reduction in TB cases and death. And for all-cause death, all scenarios eventually model everyone until their death. However, as we could see from panel C, IPT helped delay all-cause death in the early years, which eventually will lead to prolonged life expectancy. In terms of life years and disability-adjusted life years, the observed IPT scenario on average resulted in a significant 0.06 life years gained and 0.04 DALYs averted per person compared to no IPT. The full IPT scenario yielded larger health benefits at 0.12 life years gain and 0.08 dailies averted. These health benefits came with very low cost consequences. Compared to no IPT, the observed IPT on average saved $0.69 per person's lifetime, while the full IPT resulted in an extra cost at only $4.28. We also show the breakdown of cost components for the incremental costs. As we can see from the table, IPT provision was associated with direct costs of IPT drugs and increased downstream costs of ART due to longer life expectancy. But these additional costs were offset by the savings from reduced downstream TB treatment cost. Here we summarize our main findings. Our study found that the expansion of IPT coverage resulted in substantial long-term reductions in TB incidence and death. In addition, IPT is highly cost-effective. Full implementation of IPT has an ICER of $56 per daily averted, and in comparison, many studies reported an ICER of about $60 to $5,500 per daily averted for ART, which has been widely adopted in high HIV burden countries. Furthermore, even without perfect implementation, the observed IPT yielded significant health benefits with minimal cost consequences overall. Our results therefore highlight the benefit of expanding coverage of IPT among people living with HIV in limited resource settings. Different from previous studies on IPT, our study has a unique strength of being able to utilize the large, rich, and pragmatic program data from MDH to construct an individual-based simulation model. This model enabled us to analyze and inform hypothetical IPT scenarios while also accounting for realistic implementation constraints. And since our clinic-based cohort likely would get TB infection from outside of the cohort, we assumed the TB force of infection was external and did not model transmission dynamics within the cohort. Also, since we based parameters on MDH in Tanzania, our findings may not be generalizable to settings that are substantially different. Lastly, the trade-offs of studying IPT at different times after ART initiation are still unclear in the literature, and this question has been identified as an important evidence gap by the WHO. So as the next step, we plan to use our model to analyze the optimal timing of IPT with respect to ART initiation. Thank you for joining us today, and please get in touch with any questions, comments, and suggestions.
Great. Thank you, Jinyi. And now I would like to hand across to Nicola for our third scientific presentation.
Thanks, Nick.
Great.
My name is Nicola Foster, and I'm presenting some of our work from Vietnam, where we analyzed the social determinants of the decline in TB prevalence in Vietnam, looking at two TB prevalence surveys in 2007 and 2017. So, as I said before, so TB remains one of the leading causes of death, and disproportionately affects the poor and disadvantaged. Many historical studies have shown sustained reduction in TB incidence in high-income countries, and some of the hypotheses for this finding is improved living standards, reduced air pollution, nutrition, and TB treatment. But the question is whether it follows that the solution is economic growth. So in Vietnam, since about 1986, they've seen rapid and sustained economic growth, with increases in GDP per capita, and income inequality has remained stable at fairly equitable wealth distribution, the Gini coefficient of approximately 35. As I said earlier, there were two TB prevalence surveys, one in 2007 and one in 2017, and a comparative analysis found a 30% reduction in TB prevalence between these two surveys. The aim and objectives of our study was therefore to use the opportunity of the measured longitudinal trends in both poverty and tuberculosis prevalence to examine the distribution of TB by household socioeconomic position, and to also further look at individual household and neighborhood, or in this case, provincial determinants of this reduction in TB prevalence. So I have a quick slide showing our analytical framework. I won't go into too much detail other than to say that we were given that we had data from TB prevalence surveys, we were interested in the link between household socioeconomic position and TB prevalence, as well as between household absolute wealth estimates. And we were interested in, and that these interactions were mediated by interactions with health services. Okay, just very quickly on our methods, we use data from these consecutive prevalence surveys. Eligible individuals were screened by sort of household surveys, and eligible individuals were screened for TB. If they were found to be screen positive, they would receive additional TB diagnostics. Data from 94,000 and 61,000 individuals were included in the study. We had some household consumption data that we collected, and we used that to estimate absolute wealth estimates, as well as to construct asset indices for a relative socioeconomic position of the household. We then used provincial level socioeconomic indicators from the World Bank, and we constructed, in order to examine the distribution of ill health by household SEP, we constructed illness concentration curves and indices, and we investigated associations between individual, household, and neighborhood risk factors using mixed effects and multi-level models. So just trying to get to the findings quite quickly. So just looking at this study, the participants between the two surveys. So these were obviously repeated cross-sectional surveys for very similar districts. They're not exactly the same districts, but still participants were pretty similar. One of the important differences include that in the second survey, there were fewer households who would be considered wealthy, comparatively wealthy. There were more lower SES households in the second survey. In terms of the distribution between the different regions, was also quite similar, as well as between the different types of residents, between urban, rural, and remote households. During that time period, in 2009, looking at the poverty headcount between provinces, there was a reduction in poverty headcount, which was measured as the percentage of the population who were living on less than $2 per day. So looking at the illness concentration curves, if you look at where the curve that is with the curve above the equal distribution line shows us that TB prevalence was concentrated among poorer households in 2007. And if you look at the 2017 curve, it shows the curve is below the equal distribution line, suggesting that TB patients that shifted towards, and TB patients or TB disease was more equally distributed, with slightly more in the wealthier groups. So the concentration, so looking at the concentration index, we have similar results. And the multi-level models showed us that age and gender were some of the most important explanatory variables for understanding this change. Whether we looked at whether we use absolute values for understanding household deprivation as a household absolute wealth estimate, or whether we looked at differences between households with different socioeconomic status groups, we had similar results. And the most important association was the provincial poverty rate in terms of explaining the change in TB prevalence. So TB disease was initially concentrated among the poor. So just a summary of our findings with a shift towards a more equitable distribution in 2017. And this is accompanying an overall reduction in TB prevalence. After controlling for provincial poverty rates, older age, male gender, and living in an urban center were associated with increased TB prevalence, and differences in neighborhood or provincial poverty was important in explaining differences in the TB burden observed. And a limitation was that we could not assess how improvements in health services might have mediated this change in TB prevalence. And I just want to acknowledge our co-authors as well as our funder, which is the European Research Council.
Great, thank you, Nicola. And again, I hope people are recalling or writing down their questions as we move on to our final scientific talk. And I'd like to hand over to Allison for that.
Thanks, Nick. So my name is Allison Portnoy. I'm a postdoctoral fellow at the Harvard T.H. Chan School of Public Health. Today I'm going to present an application of a full value of vaccines assessment framework to novel tuberculosis or TB vaccines. Right up front, I would like to acknowledge all of my co-authors on this work and thank the World Health Organization for their support. So as generally has been already mentioned, for a disease with substantial burden in low and middle income countries, such as TB, it will be essential to address the value of novel TB vaccines beyond the direct health benefits of vaccine introduction. Therefore, we have adopted the WHO full value of vaccines assessment framework, which is forthcoming in publication by Raymond Hu-Tibesi et al., which includes the broader benefits of vaccines in order to guide diverse stakeholders in organizing global level efforts to invest in novel TB vaccines in the future. So understandably, the objective of the study, therefore, was to apply the full value of vaccines assessment framework, articulating these broader health and economic impact of new TB vaccines, considering both country governments and multinational partners to make the case for the expedited development, adoption, and implementation of these vaccines. So for our vaccination scenarios in the base case, we examine a routine vaccination of 9-year-olds and a single mass campaign of ages 10 and over with country-specific introduction years over 2028 to 2047 and within country coverage targets attained over a 5-year period. And that 2028 starting point is the expected licensure for a future TB vaccine. We also examine an optimistic scenario that's similar to the base case and efficacy assumptions, but assumes that all countries are introducing in the year 2028 and that vaccine coverage targets are reached instantaneously. All of these vaccine scenarios are compared to a scenario with no new vaccine introduction, and we assume that this adolescent vaccine product has 50% efficacy based on the data described by Matt in the earlier presentation. So in our pre-recorded presentation, we presented 9 different analytic approaches that we're applying to novel TB vaccines as part of the full value of vaccines framework. But today I'm going to focus on just a subset of the value for money analyses, including cost effectiveness analysis and a return on investment analysis presented as a net monetary benefit. So first of all, we look at a health system perspective, cost effectiveness analysis, there are several data requirements that necessitated obtaining country-specific values for the healthcare costs. So we rely on available published literature for TB testing and diagnostic costs, these C-test, and those are stratified by drug susceptible and drug resistant TB. We've also conducted our own meta-analysis of ART costs based on studies reported by the Global Health Costing Consortium, and as Matt mentioned earlier, our own meta-analysis of vaccine delivery costs. Then we also conduct a societal perspective CA, so we need societal costs, and here we use WHO Global TB Program patient cost survey data for both the needed direct non-medical as well as patient time costs. And then you can see that we also are monetizing the productivity lost due to premature death with this YLL component. So here we are referring to years of life lost due to premature death for the just as productive YLLs for this formula, whereas in the disability adjusted life years, we use the full years of life lost. Then as I mentioned, we also conduct a return on investment analysis in the form of a net monetary benefit. And here we assume multiple proxies for willingness to pay or cost effectiveness thresholds. But for the purposes of this presentation, I'm going to focus on a 1 times GDP per capita threshold in the subsequent results slides. So here, looking at a cost effectiveness plane with cost per 1,000 population on the x-axis and benefits per 1,000 population on the y-axis, we can see that novel TB vaccination produces positive benefits for positive costs in all 92 countries that we examined. vaccination was cost effective at a 1 times GDP per capita threshold in 59 out of the 92 countries. So again, these results are for the health system perspective, which excludes those non-medical and productivity costs. However, if we look at an example country highlighted here, and we switch to the societal perspective on the next slide, we can see that this specific point moves to actually be cost saving in the specified setting, as well as 5 additional settings. So these 6 settings where TB vaccine becomes cost saving are among the top 30 high burden TB countries according to the WHO. And generally the differences in benefits along the y-axis are due to these differences in TB burden by country. Overall, switching from the health system to the societal perspective yields results that are cost effective at lower thresholds in all countries. So alternatively, we can look at results in terms of a net monetary benefit, here shown on the log scale for easier visualization along the y-axis by country along the x-axis. Once again, the countries with the highest net monetary benefit are among the top 30 high burden TB countries according to WHO, and are also countries with large population sizes, including South Africa, Philippines, Indonesia, India, and China. If we instead examine an optimistic scenario of instantaneous scale up of target coverage with all countries introducing in 2028, we can see that the net monetary benefit substantially increases from the base case scenario in blue to the higher levels in red, in some cases actually increasing by an order of magnitude. So this analysis includes several limitations. First of all, we were constrained by data availability for many low and middle income country settings, and only 92 countries were successfully parameterized and calibrated. However, these 92 countries represent 94% of LMIC TB incidence and 91% of LMIC TB mortality. Additionally, this is not a comprehensive set of analyses, but are being modeled to demonstrate the potential value of novel TB vaccines according to specified characteristics. So finally, our study provides a full value of vaccines assessment that could help support a range of decisions for future development, adoption, and implementation of novel TB vaccines. And the results of these analyses will inform decision-making around TB vaccine development and introduction by various global and country stakeholders. Thank you very much.
Great. Thank you, Allison. And now for our sort of final sort of structured part of the section, I'd like to hand over to Sedona as our discussant.
Thanks, Nick. Let me just share my screen. All right. So I have the pleasure of presenting sort of a summary of each of the presentations that we've seen so far today. And just reflecting sort of my opinions on some of the methodological advances that we've seen today, and some remaining questions. And thanks to the presenters who sent me their slides ahead of time, so I've lifted some of your figures to make my points. So just to summarize, so we had 4 excellent presentations, all really on, I mean, so the title of the session was the economics of TB in low and middle income countries, but it really could have been the economics of TB prevention in low and middle income countries. So we had Matt and Allison both presented cost effectiveness analyses of vaccination. Ginny presented cost effectiveness analysis of prevention through IPT among people living with HIV. And Nicola's work really shows us, you know, what additional prevention there can be through addressing social determinants. So, you know, removing the root cause of TB. So I'm going to reflect on a few of what I see of important methodological contributions in these presentations. So the first thing is that all of these presentations show excellent examples of integration of epidemiological and economic analyses. So Nicola, for example, used epidemiological data and methods to sort of answer an economic problem. We had lots of sort of integration of epidemiological mathematical models, showing us the long-term effects of things like vaccines and IPT. Next is consideration of wider societal costs and effects. And I think this is really important. I mean, this is one of my personal bugbears, and we've seen in Allison's presentation specifically how important this can be in your, in changing the decision, especially where the burden is high. If you include costs outside of just the direct costs and just to the health system, you start to see that it actually does save money across society. The other thing is consideration of downstream health impact. So we saw in Jinyi's presentation that providing IPT decreases the cost of TB treatment, but increases the cost of ART due to prolonged life expectancy. So this makes sense, especially in the context of preventive interventions, where we do need to start thinking about optimization and including sort of a wider variety of illnesses. Illnesses don't happen in, it's not a vertical world. Nothing happens in a silo. So we do need to consider what else is going on for these patients. Next is that all of the presentations sort of adopted some really great methods to extrapolate what was fairly limited data. So taking different assumptions around scale up, for example, of interventions, or taking different assumptions around the effectiveness of the vaccine from Matt, and showing, what that assumption might lead to, in your decision. I thought that was really, really interesting and really, really cool to see, how much the actual assumptions of your model changes your results in your decision. And then finally, on extrapolation of limited data, it was, there's extrapolation of epidemiological data, but then there's also extrapolation of cost data. So I've pulled this map from the Global Health Cost Consortium Unit Cost Study Repository, which shows data availability as of 2018, when the Unit Cost Study Repository was last updated, on TB prevention. And you can see there are 5 countries for which there are like 1 or 2 estimates of unit cost data. So the work that you all are doing in producing those unit cost estimates is great. And then the work that you're also doing to sort of help inform extrapolation of the cost data that does exist to answer new questions in different settings and really sort of help this data go the extra mile is really great. And then finally, just reflecting on some lessons for future work. So I think, these presentations are all, huge contributions, but I think there are some remaining questions, and I've put some up here, and I'm sure, other people have more. So Matt, for example, we looked at clinical trials of vaccines, and one of your conclusions is that you should potentially be including more adolescents in clinical trials of vaccines. So what else should we be including in clinical trials going forward? Should we be including different population types, potentially collecting different types of data? Would that really help us to answer these types of questions going forward? Next, what more should be included as part of routine data collection? So I know from the cost side, this is a constant struggle in that we don't have routine cost data. But I think, Nicola, you mentioned also potentially just better socioeconomic status indicators. Could we be collecting things as part of prevalence surveys or as part of national surveys that would facilitate sort of, better understanding of the TB epidemiology going forward? Next, how best to consider health system capacity when extrapolating? Are our assumptions of the ideal scenario, accurate? And what kind of data do you think would make these analyses potentially better appropriate to reflect what might actually happen in reality? And then finally, just reflecting maybe a bit more broadly and drawing a bit from Nicola's work, in that we presented 2 technologies, vaccine and IPT, and then we presented one more sort of potential for preventing TB by addressing social determinants rather than just introducing new technologies. So are we focusing too much on introducing new technologies and not enough on addressing the root cause of why people are actually getting TB? So that's all from me. I'll pass it back to Nick. Thanks.
Great. Thank you, Sedona, and thank you to Sedona and all the presenters for sticking to time. I think we now have about 20 minutes of sort of unstructured discussion time. In terms of asking questions, you can either put a question in the chat, in which case I will hopefully see it and read it out, or you can put up your virtual hand, or you can put up your actual hand and I will see that and call on you, and then you can ask your question verbally. As I said before, please keep any questions constructive and concrete. Please try to avoid questions which are actually short presentations framed as a question. And please, when you do ask a question, mention the presenter who you're asking your question to, which might be one or might be several. And so at that point, I'd like to open the floor to any questions. Well, as the chair, I can get to ask my own questions. And so, Nicola, I have a question for you, and focusing on the ones of non-intervention related talk. So you mentioned a number of times in your presentation that you looked at, I think, absolute wealth. Now, there are obviously in other settings we're sort of more keenly interested in relative wealth when we're understanding patterns of sort of health and changes in health in society. And so I'm wondering, what your thinking was about sort of that decision, and if you thought that the results would have changed if you'd looked at sort of relative wealth instead.
Thanks, Nick. I think that's a good point. So in our presentation, I think I skipped over that the more detailed results slide, the last results slide. But we in reality looked at both absolute measures of poverty. So we constructed an absolute wealth estimate for each household, and we also had relative measures. So we had a socioeconomic position indicator, which is an asset index. So we looked at both, and it didn't change the conclusions of our results. Looking at both, I think for us one of the challenges was that only having a relative index and using a relative index that was based on asset questions that were asked in 2007 and 2017. The questions were slightly different between the two surveys, and so in order to make that comparative, we tried to use the same asset questions in the analysis of the relative index, but obviously that is really hard to then understand what changes happened in the population over time, and that's why we also used an absolute wealth estimate as well. Does that answer your question? I think you're on mute.
I've been on Zoom for the last, 14 months, and yet I still, sorry, okay. Yes, thank you, that does answer my question. Right, now I have a list of questions here, but I do want to give people the opportunity to jump in. All right, so this is a question which actually applies to the analyses by Allison, Ginny, and Matt. And so I'd like to, so with the vaccine interventions, right, we're looking at an intervention which should hopefully turn up, given some further product development, given some sort of working out how to implement the intervention. I'd like to describe another intervention, which is something we know about it. We've got great data on how to implement it. We've seen it work in trials and pragmatic trials and program evaluations. Obviously, this is IPT I'm talking about, where, so Ginny looked at Tanzania, which I think had national coverage of 5 or 7%. If you look across the sort of high HIV TB burden countries, you see a fairly similar pattern, right? Tanzania's at the lower end, but still, so most countries do not have the kinds of levels of coverage of this cheap, affordable, effective vaccine, treatment that we would like to see. And so I guess for Allison and Matt, so do you see any barriers or any questions we need to ask analytically before thinking that, you know, evidence of cost effectiveness is going to be sufficient to justify or to encourage people to roll out this new technology when we get it?
Thanks, Nick. I think that's a really great question. And I think this goes back to kind of the idea of within cost effectiveness analyses, you can really only select the optimal intervention or combination of interventions if you're including that comparator in your analysis to begin with. And this is one of the kind of, I guess, there's a long-standing need for improvement in this area, particularly with diseases where there's measures across the disease spectrum or different approaches to both prevention and treatment. So, often we use like a no new vaccine introduction or a status quo comparator for any time we have a new technology or a new intervention, but aren't doing the same in terms of thinking about the other potential comparators, whether they're being scaled up or not. And I think like this is a really great example of why in the analyses that we're conducting for the WHO, we wanted to make sure to provide an alternative baseline comparator, which essentially we're going to proxy the idea for IPT scale up by looking at kind of a general prevention scale up to map to the in-TB strategy goals. And so we will expect that the cost effectiveness profile of TB vaccine will change therefore, but hopefully that provides like a more complete picture.
Thanks. Nick, so I'm going to interpret your question slightly differently of how do we know that 80% of people are going to use this vaccine when we introduce it? We've got IPT that no one's using now. So how do we know a vaccine is going to be any different? And I'm going to frame this in what we've learned over the last year and a half, well, the last year really, when it comes to COVID vaccines. And, I speaking here from London, who would have thought that the UK would be vaccinating 2 million people a week outside of, routine healthcare, given, 24 months ago, we weren't even modeling that as like the most optimistic assumptions of any model of any country. So I think COVID has shown us that some decisions are made when cost is no object, but when it comes to tuberculosis, cost seems to be a huge object. And I mean cost in terms of financial cost, in terms of the money that we have to pay, but also in terms of constraints on the health system and non-financial constraints that I know others, particularly Fiametta, who was on earlier, who's just dropped off, has been working on. So I think it's really important that our models show how cost effective these can be with assumptions around feasible scenarios that we've seen as it comes to COVID. This is the best it could probably get. I highlighted in my presentation, this is probably the cheapest it's probably going to get as well. So I see these models as almost at this stage being advocacy models. Then when we move to implementing vaccines, we move to phase 3 trials and demonstration products, and we get the data that Sedona highlighted that we need. That's when we fill in the gaps and we work out where are the bottlenecks, where are the inefficiencies that we need to tackle in the pipeline. Over.
Great, thank you. I know, Ginny, if you wanted to comment on that at all.
Yeah, I had a few thoughts just based on my experience working on this IPT project. So I think we have talked about this a lot, but one of the reasons why it hasn't been scaled up is probably because the benefits are accrued like in the long term, but we see the cost right after we give out the IPT. So it's very important to show the decision makers where do like benefits occur and when do these like benefits actually get actually show up in the trajectory. And also one of the concerns our local collaborators talked about was the potential drug resistance induced by IPT. And I think it's like a valid concern, but it's important to quantify how large that concern actually is. And we included that in our model and can still show that IPT is highly cost effective. So I think these are important lessons we learned from IPT and can also be applied to potential new interventions.
Great, thank you, Ginny. Now again, I'll pause to see if anyone or any of the other presenters have any questions. And just so you know, Sedona, I've got a question for you coming up if no one else has any.
Okay, well, in the meantime, if nobody else has a question, I've got a question. I suppose for Allison and Matt, but also the other two. So just curious if so based on the analysis that you've done so far, and the struggles that you've encountered and some of the assumptions that you've had to take, if they were to do sort of further clinical trials of vaccines, phase 3 trials, and sort of build up the evidence base, what data do you think would be really important to collect that you don't think that they're currently collecting?
Well, I think in terms of parameterizing these models, one of the pieces we generally, I think the patient perspective, we luckily have these patient cost surveys the WHO has conducted, but again, in very limited settings that we're trying to extrapolate to more settings, and having to do like some, they weren't really directly collecting income in a rigorous way, but we we're able to use that information in a different way for our purposes. So that goes back to your earlier point, both Nicola and Sedona, about better SES collection and indicators alongside these either cost or prevalence surveys. But honestly, the biggest piece for me is kind of a little bit different in terms of doing a better job at incremental costs. So it's it's not within the clinical trial, I think, context. It's more, alongside interventions to scale up coverage, doing a better job in alongside those interventions to also collect cost data, because that's where we really struggle with actually extrapolating costs to scale up from one coverage level to another. We do kind of have most of what we're capable of doing is predicting costs at a current coverage level. So that's the major gap that I see.
Yeah, I totally agree with that, what Allison has said. I think there's two things in particular that come to my mind. It's a really nice question. First, on sort of a trial point of view, the extent to which a vaccine offers this pre-infection efficacy, that it stops you from getting infected with TB, is just something we don't know. We've seen in the COVID vaccine trials, the endpoint for the COVID trials is that a symptomatic a fever is a failure of the vaccine. It's really easy to measure. People get sick and people report it. Infection with no symptoms is very difficult to measure. Basically, you need to test loads of people. So that data comes a bit later. So the next step in the trials is to work out some either clever trial designs or some interesting endpoints to work out if the vaccines offer pre-infection efficacy. The other parameter that I think is key, in particular in South Africa and India, the settings that we modeled in the study I presented, is how much of a pain is it going to be to reach these adolescents? So basically, how much is it going to cost to get your marginal adolescent to come and get a jab? And that's going to be different for 12-year-olds to 15-year-olds to 18-year-olds, because we all know adolescents are a pain, but how much of a pain are they going to be and how much is it going to cost to reach them, I think is going to be key.
Great, thank you. And Sedona, that was actually the question I was going to ask you. So I'm going to move on from that one. And so I have another question for Nicola. So in your results, I was interested about the relationship between urbanicity and SES and TB. Then I think there was this changing relationship of TB with SES, but then I think you found that TB was also higher amongst urban residents. And then I'm also now in my head filling in the fact that that wealth is typically higher in urban areas. I'm not sure if that's true at all, but I was wondering if there was anything in those sort of the relationship between those three things.
Thanks, Nick. That's a really good question. So I think what we saw from the analysis was that yes, there was this increase in risk if people were in the urban settings. And the juxtaposition was that households who were based in urban settings were generally slightly wealthier. So I think it's probably a question that needs a little bit more exploration.
All right. Great. So we'll probably have time for one more question, if there is one. And again, to those, to the non-myself, the non-discussant, the non-presenters, please do feel empowered to ask a question if you have one. If you have a question and feel that, you know, it's a bad question, don't worry. If you think it, likely other people have the same thought. So please do feel free to ask a question. Okay, you're all off the hook. So I think we can all pat ourselves on the back for finishing on time. I'd like to thank each of the presenters for a very clear and sort of timely and thoughtful talk. Thank you, Sedona, for the great discussion. Thank you for everyone joining. If you have any follow-up questions, please feel free to follow up with each of the presenters individually, or they, as they mentioned, have shared more detailed either slides or presentations on the conference website. And with that, I'd like to close the session. Thank you, everybody.